Good morning, everyone. Thank you for joining us for today's webinar about preliminary cost effectiveness findings from Project Homes. My name is Steve Herrera, and I am project manager with Project Homes at the University of Texas Health Science Center at Houston School of Public Health. Today's webinar is hosted by the Michael and Susan Dell Center for Healthy Living at the UTHealth School of Public Health in Austin. The center's vision is healthy children in a healthy world, with a mission to advance health and healthy living for children and families through early and impactful interventions. Information about the center's work and resources can be found online. Please scan the QR code on your screen to access our health resources. The slides and a recording of today's webinar will be archived on our website, msdcenter.org. If you have any questions during the presentation, please enter them in the Q&A section. With that, I'm excited to introduce our speakers, Dr. Michael Wilkerson and Dr. Shelton Brown. Dr. Wilkerson is an associate professor in the Department of Health Promotion and Behavioral Sciences at UTHealth Houston School of Public Health. He also serves as faculty co-coordinator for the Health Disparity Certificate Program. His research focuses on the identification of individual and structural determinants that contribute to health disparities among marginalized population and the development and evaluation of health promotion programs, in particular substance use recovery and HIV/STI prevention. Currently, he is funded to evaluate recovery residences for persons participating in medication-assisted recovery and a certification program for peer recovery support specialists. Dr. Brown has been a faculty member at UTHealth Houston for over 20 years. He is a health economist and has worked on a variety of health topics. Recently, he has worked on the cost effectiveness of substance use disorder recovery programs and has created a cost effectiveness calculator for naloxone and long-term peer support programs with Dr. Sierra Castedo de Martel. I'll now hand it over to our speakers with their presentation on Funding Recovery Housing, Preliminary Cost Effectiveness Findings from Project Homes.
Thanks, Steve. Hi, guys. Like Steve said, my name is Mike Wilkerson. I am really excited to do this presentation today with Dr. Brown. He's going to share what I think is some really exciting findings. So I'm going to give a very brief presentation just to tell you about the project and what we're doing here in Texas. And then I'm really going to turn it over to Dr. Brown. Next slide. So Project Homes. Oh, quick disclosure statement. Anything we say today is not necessarily the views of the state of Texas or our funder. We are incredibly blessed, I will say, to have funding from the state of Texas Health and Human Services. This is a really unique model, and I think a really great example of how the state of Texas is doing really good work to provide services to people who otherwise would probably not be able to access it. And so I'm really excited and I'm grateful for the state support, but anything we say today does not represent the state. Next slide. If you want to learn more about our work or our team, and specifically Project Homes, I encourage you to go to these URLs. At the top, you'll see go.uth.edu/homes. That is the specific project website. That is a community-facing website. So if you know of someone who might benefit from recovery housing, and they are in the state of Texas, please share this link. And if they fill out a short form, we will get them linked up to one of our housing providers. If you want to learn more about our research team and the work that we do, including Project Homes, you can go to the CoLab website. Next slide. And so Project Homes, we have 3 components. So Project Homes has 16 homes across the state of Texas. And I believe the next slide will go into those houses. But essentially, we have three components to the project. The first component is providing recovery housing. And we work with 12 community partners across the state of Texas on various aspects of this project. Five of those partners or six of those partners, excuse me, are our housing partners. And they provide housing for people using medications to help treat an opioid use disorder. And then we have some of our homes that also treat folks with a stimulant use disorder. So one component is just providing housing with our partners. The second component is a certification and a technical assistance program. And so all of our houses must be certified through the National Association of Recovery Residences local affiliate, which is the Texas Recovery Oriented Housing Network, or TRON as we call it. And then the third component is a program evaluation component, of which this cost effectiveness analysis is a component. Next slide. And so our houses, we actually now have 16 houses in Texas because, oh no, it is 15. I thought it was 16. Anyway, it doesn't matter. Maybe my math is wrong this morning. We have 3 houses in Midland. 2 of those houses take women with children. 1 takes men. We have 4 houses in Austin, 2 take women, 2 take men, 2 houses in San Angelo, 1 with women, 1 with men. We have 5 houses in Houston, and that 5th one we just added, which in my mind was the 16th, but it really is 15, so apologize for that. But we have 4 houses in Houston, 2 with women, 2 with children, and we just added a 5th house that takes women with children, which is really exciting. And then in El Paso, we have 2 houses, 1 for women and 1 for men. Next slide. So with that, I just wanted to give that quick overview of what is Project Homes. If you have more questions about the project, I'm happy to tell you more about it later, but I really want to give this time to Dr. Brown to share his presentation.
Okay. Yes. So basically, yeah, my part is to do a cost effectiveness study of Project Homes. And, I guess what I would like to do here is talk about sort of how to have a couple of slides to kind of orient you about the way to think about this. The main thing is that I think a lot of people, they think cost effectiveness, they only think about saving money, but really what we're trying to do is relate benefits. In our case, the benefits are going to be qualities. It could be something else. I'll have a couple of other slides with alternatives, alternative benefits. But if the cost per benefit is lower than a certain threshold, then we say it's cost effective. And it's kind of a way to rank different types of things we can do, either public health, prevention, it could be surgery. All right. So for instance, here's some on the right hand the screen. So anything, this is golf. So anything that if the ICER, which is the incremental cost per cost effectiveness ratio, as it gets lower, it's more attractive. So it's like golf. Okay, so whatever you've got the cost of the intervention or the surgery, whatever it is, in the numerator, in the denominator, you've got the qualities added. Those are quality adjusted life years, which I'll define here in a minute. The lower, the better. Okay, and sort of like this is anything that's green is a go. Anything that's red is maybe too expensive for the benefit. So these are just some examples. We will put, there's a lot of people that have annual pap smear. It's not particularly cost effective. If you do it, every other year it is. Okay. So it's kind of like in that case, if you're getting your 15th booster for COVID, you might not get that much benefit, but there's a cost. And so the 15th would not be cost effective, whereas like maybe the 3rd would be. Okay. And so anything that we do in health, public health, or in medicine can be kind of put in this big league table. So that's where we're going. So we want to see where Homes is. Okay, next. Okay, so another way to think about this is think about when you go to don't overthink this. Sometimes the model behind it seems complicated, but you've all been shopping. Anybody that likes ketchup, you just want to look at the cost per ounce. I just was talking about earlier, we're going to look at the cost per quality with homes. So we have to model out the qualities, but in this case, it's just the cost per ounce. The smart money doesn't look at the flashy packaging or whatever, the label. You're just going to go with the lowest cost per ounce. In this case, it's Hunt's ketchup, so it's exactly the same. Doesn't matter. You should go with the one on the right. Actually, I guess usually it's the other way around. The bigger bottle is cheaper per ounce, but in this case, that's not the case. Okay, next. Okay, so this is the formula. Okay, so we're going to have the cost of the intervention. Now that is the cost of homes minus averted costs. Okay, minus treatment as usual. And I'll set this up a little bit later, and there might be some averted costs with treatment as usual as well. And then we're going to have the intervention effect. In our case, this is QALYs, okay, versus the QALYs you would get with normal treatment. Basically, it's going to be, these are all people who are in recovery, and they're in some sort of MOUD, okay, for opioids. So both of the groups would be the same in treatment as usual. If I don't have it, I'm going to call treatment as usual as TAU. That's the acronym. Okay, so basically it's the cost, which is the numerator, and the denominator, we got the benefit. So sometimes you might see something like the cost per quit if this is tobacco, because there's so many different tobacco programs. If you get someone to quitting, then the modeling is kind of the same afterwards. Okay, and we're going to talk about the health system and the societal perspective. The health system is mainly going to be the medical costs. The societal perspective, we're going to have, avoiding judicial involvement. So those are two perspectives. So the perspective comes from the fact that, say you're an insurer, your perspective would not include the out-of-pocket part because you don't pay that. You're just interested in what you're paying. So that's why we talk about perspectives. So we'll probably do a version of this from the perspective of the state. I'll talk more about that later. But basically what we want to do is we want to see if we're getting a good dollar value for good stuff. In our case, that's recovery. People have more QALYs. That means they're healthier. They're in recovery. Okay, next. Okay, so QALYs are, like I was saying, the life year. If there's epi people out there, if you've kind of labored with life tables, you kind of understand life years. Quality adjustment, we just put in a weight, okay, bounded by 0 and 1 for each year. So basically, if you're at a 1, you're in perfect health, no problems. You are, you don't have any limitations in what you can do. You can do your job. You can go shopping. You can bathe yourself. All sorts of things. Okay, and if you're at a 1, then basically you're near death. Okay, your health is low, and you've got like a lot of limitations. And for people that might be going through chemo or something, sometimes QALYs can be like negative, below 0. But what we're going to do for this is we're going to use Sierra Castedo de Martel, who is a frequent co-author with mine. She basically has come up with a quality weight of 0.714, so closer to 1 than Whiteford's for if you have SUD. Okay, then basically you're at about a half, a 0.86. So if you're in recovery, you get more credit in this model, okay, because that's a healthier year. Okay, next. You guys can jump in if you have any questions. I think one thing I think basically I don't like to feel like the Wizard of Oz. I don't, sometimes when you're, there's like here's some numbers, something happens, and then numbers get spit out and flames go up if it's the Wizard of Oz. I kind of would rather like explain kind of what's going on under the hood. Okay, and so think about musical chairs. If you're foreign born, basically it's a game that they play at birthday parties with kids. You have like let's say 6 chairs, 7 kids. You play music, stop the music, they all sit down. One isn't going to be able to sit down, they're out, and then you pull another chair away and you keep going. So really a Markov chain is one way. So what we're doing here is we're getting at the good stuff. So how do we measure the good stuff? Okay, this is sort of an example. And so here, we'll just, pretend a round of musical chairs is like a year of a life. Okay, so you basically the first year there's 7 kids. There's a 1/7 mortality. All right, so that means we have 6 life years, and we're going to assume that the person died halfway between the round. So we give you another half a year. And then we're going to do something that we do in economics called discounting. We're going to discount at say 3% when we're doing that with project homes as well. The basic idea is that you want good stuff now. If I tell you you won, congratulations, you won Powerball lottery for I don't know how many billions of dollars, and you get come by tomorrow to get your check, versus telling you get it when you're 95. You'd rather get it now, right? Okay, so we sort of have a way to correct for when the good stuff comes, but it also works if there's like costs later on. That's better too. You want to push those out. So basically, their kids are playing the game. They're playing the game. So the second round, there's 5 chairs, 6 kids. There's a 1/6 mortality. Next round, 4 chairs, 5 kids, 1 out of 5. And so basically we just add up the life years. Okay, um, and then basically we discount, and this is the sum of the qualities that we get. We're doing something like this, with homes, and I'll give you some of the details here. Then let's suppose we have an intervention. I'm going to call it project chair. I'm the PI. Okay, and basically what we're going to do is we're just going to add another chair in the second round. So we play it normally the first round, so the first rows are the same. Then we've got like 7. We add another chair back, and so the mortality rate is 0. So you can kind of see you get another half a life here because nobody dies in the second round. Then you just continue, and we're going to discount in the same way. And so and then basically you can kind of see that everything gets shifted down because nobody dies in the second round. So what were the life years gained? I'm just going to take, so this is the sum for project chair. This is our intervention. This is treatment as usual. All right, and so we've gained 5 discounted qualities. All right, so thinking about, like, let's say we made the threshold be 50,000. How expensive can the chair be and have that be cost effective? Morella, maybe if somebody could put it in the chat, we'll celebrate whatever their team's nickname is for being right. So basically what you do is you just multiply that by 50,000. So it can be like a $250,000 for the chair, and it's going to be cost effective. Okay. All right. Next. Okay, so our Markov chain, it's going to be a little bit different. We're going to have 3 states. We're going to have OUD, and I'm not defining that opioid use disorder because I was thinking the audience would know that. We're going to have recovered or deceased. So it's a little bit more complicated, well, a lot more complicated than musical chairs. We've got 3 different states. You can't be in any of the states. Once you're deceased, you're out of the game permanently. People with OUD can transition to the recovery state without help. We have that happens in like 2%. So if we don't have project homes or anything, a very small percentage might be able to make it to recovery. Those in recovery can transition back to OUD, but the likelihood falls with the length of time in recovery, as we'll see later, mainly like at 3 years. If you can be in recovery for 3 years, it stabilizes. Where our model goes from age 36 to age 82, and the QALYs and averted costs are discounted at 3%. Okay, so that was like in the slide before. Okay, so next. Okay, so again, what we're going to do is we're really kind of going to make an artificial control known as treatment as usual, TAU. All right, so we're going to start with 2 sets of 1,000 people in recovery. Basically, they're all going to be on MOUD at the start. Okay, so that's a cost for both of the groups. Okay, and right. So one thing to keep in mind, whether you're in recovery or not, you basically can be hit by a bus, right? Okay. So or you can something can happen. So we're gonna have you can enter. We got mortality rates to enter the deceased state, whether in your recovery or in OUD. All right, and of course that increases by age. We found a study that looked at, it was mainly OUD, but they were looking at SUD, and they pooled a bunch of research studies. And so we have sort of the OUD attributable extra death rate, okay, by age, okay, and um, and so um, and so basically we sort of add that to the mortality rate, all right, and so that's what you would get if you're in the OUD state. If you're in recovery, you have the normal mortality, okay. All right, and so like we were saying, the recurrence rates kind of stabilize after 3 periods. Okay, next. Okay, so this is sort of like I was saying, I don't want to be the Wizard of Oz. I'm kind of like showing you guys under the hood here a little bit. So basically, these are the 3 states: active OUD, recovery, or dead. Okay, and so we've got 2 different probabilities. So what happens is you go into homes versus treatment as usual, and the main difference is going to be in the recovery. If you're in recovery, so the first year. If you were in homes, this is based on our empirical outcome. Basically, you've got a 71% chance, of staying in the recovered state, going into the second year. Okay, after being in recovery. So in that year, you were in homes. Okay, and this is sort of what you would get with treatment as usual. And we got this from the literature. Okay, and of course, if you're in the deceased state, you're going to be you stay there with certainty. Um, Sometimes I call that the no zombie assumption. Okay, and then so basically this is the first year, and the main difference, like I say, is if you're not in recovery homes, you basically have a 21 percentage point higher chance, a lower chance of staying in recovery. So you'll go back to active OUD. Then you have like a lower QALYs, and you have a higher chance of making it into the deceased state. All right. So then this is the second year. So this is when they'd be 37. You can kind of see it kind of stabilizes. If you're in the recovery state, you're more likely to stay there. That's also true with treatment as usual. And then by the third, year, this would be when they're 38. Basically, you can kind of see you only have a 14% of the people who are in recovery will go back to active at OUD. So homes and treatment as usual are the same from the third row on. Okay, and so you might say, well, if the probability is the same after the first 2 rounds, what's the effect of homes? Next. Marilla, next. Okay, yeah, you got it. No, sorry, you got it. Back, well, yeah, there you go. Yeah, so the slide looks so similar, I thought, yeah. So anyway, so basically you can kind of see that because, the homes actually had a lot more people stay in recovery. You can see that in the second year, out of 1,000 people, there were 272 that returned to active OUD that come out of homes. But at 37, with treatment as usual, far more, basically over 200 more would go back to active OUD. Okay. And so the numbers are different. So it's kind of like, I don't know if you're thinking about it like a Plinko model, wherever the little disc goes, that's where the action is, even though the probabilities are the same. Homes drives people more towards recovery. Okay. And so basically, that's why we're going to end up with a gain in qualities. Okay, next. Okay, so sort of some of the mundane, I guess, costs of the program. All right, so we basically looked up the gross rent that includes utilities for average for a 4-bedroom house in Texas in 2023. We added that. We assumed that there were two residents per bedroom, and they stayed for 4 months. Okay, so we have that as like a cost. It is true that a very small percentage of the people come into homes, either from jail or being unhoused. Okay, and in those cases, that this is kind of a new cost. The vast majority were already, you know, housed. Okay, and so basically, this is not a new cost. They're basically, instead of paying rent themselves, in this case, the state would pay it, but it's not a new cost. So it's not an incremental cost for homes, but we included it just to be conservative. Also, the state is paying the rent in this case. So from the state perspective, we would want to include it. All right. So the housing manager, we added like the 4-month portion of the manager's salary per resident. Okay, so basically we're just going to take 4 months of their wage, and then divide by the number of people that were there during those on average are there for 4 months. And then the other thing we did is that we looked at the residence time. Now this is actually going to be the biggest cost, and we're going to do the analysis with this and without this. So, we're all here. I guess we're 29 minutes in. There was an opportunity cost for each one of you guys. I'm hoping that these 29 minutes that you chose to be with us were worth what your your alternative use, but every minute has so people are coming in for 4 months, and so I looked up the average wage in Texas, and put in 4 months at $22.10, I believe it was. Okay, now this is not borne by the state. So if we're looking at this state perspective, they're not paying the residents. Okay, so we're going to do it with and without. And then some of the residents do work. So, we could adjust it further by like trying to estimate how many people are still employed, because then they don't have that opportunity cost. But that's something we'll do later on. Okay, next. Okay. All right. So the main thing that was happening, about half of the houses offered, peer recovery coaching. Okay, and we've got the wage from that from the previous work that I've done with this team and with another team. So we basically have that. So we basically have their portion of the week that they had peer recovery coaching. I think it was about half the houses. We're still working on the educational part, but we think that the cost will be low. The peer recovery coaching part was fairly small percentage of the overall cost. Like I said, the main thing is the rent, and um, the rent and the opportunity cost for the residents. Okay, and then we kind of omitted food and travel costs. I don't think food, like I was saying with housing, it's not really an incremental cost. There, people were eating before. Okay, and I think most have their pay their own food bill, and they got a kitchen there. But there's some houses that provide a little bit of food, and the travel costs were fairly trivial. Okay, next. Okay, so this is one thing that I thought was a little bit different than if you see me present on the calculators. So basically, there's a paper out in 2023. Okay, and what they did is they looked at people that were employer sponsored insurance. Okay, and they looked at people with OUD and various SUDs, and they looked at their inpatient, outpatient, and medical costs, and it was close to $12,000 annually, and it was all attributable to OUD. I was actually kind of surprised it was that high. I'm gonna take a look, and I didn't have time to do it before this, but I want to see. I'm assuming this is really right skewed. There's some people that have very high costs, and that maybe pulls the mean up a little bit. So this is the mean. So basically, when we're going through the Markov chain, if you're in the active OUD state for that year, this would be your extra cost. So, and if homes can keep people out of that state, that's an averted cost. Okay, and then we also had the societal costs, that basically we did that with a different system. And so that's the averted justice system involvement. And so that's from Sarah's new paper. And the cost there was, 7,500 or so annually. So if you're in the active OUD state, it's say age 42, okay, then basically on average, you're going to have this extra cost that's attributable to OUD. If you're in recovery, you don't. That's sort of the way it works. Okay, next. Okay, so yeah, so ran it through the model, and so this is all per. Remember, we had 1,000 people in treatment as usual, 1,000 people in recovery homes. Okay, and on average, there were a lot of qualities that out of 1,000 that were saved. Okay, due to project homes in this model. But basically per person, it was about, a fifth of a year, a fifth of a quality. Okay, so we were you can think if you get, so that's going to be, 5 divided by, well, anyway, so it's, you know, um, doesn't sound like a lot, but that actually is a lot. Okay, the averted costs were about 10,600. Averted societal costs were 6,867. Again, all of these are discounted at 3% each for each age that we went through. Okay, and okay, next. So basically, what that means is that the ICER, from the medical perspective, is 44,000 per quality. That 20 years ago, 50,000 was a threshold because of the dialysis standard. We have a law in this country. If you need dialysis, you're automatically in Medicare. You get dialysis, which 20 years ago cost 50,000. Now it's more like 80. Okay, so most people, would say what our threshold is 100,000 or higher even. And so from the societal perspective, it's 97,000 per quality. Now, this is also being driven a lot by the residence time. So if we take out the residence time, we see that from the medical and societal perspective, it's cost saving. So in other words, the cost of project homes, once you take out the averted medical costs, they're basically the averted medical cost is higher than the cost of project homes. Okay, and so that means that it's saving money. I wish I'd put the formula here, but if you think the numerator, that means that the numerator is negative. Averted costs outweigh the project home. That's kind of unusual. I think it's kind of driven by, the fact that the OUD costs per year are so high. I meant to say when I was talking about that one, actually go to the next one. Yeah, so basically, let me just summarize. The cost of homes is cost effective with or without resident time costs. And we looked at the societal and medical perspective, and it's cost saving if you leave out the resident time. The other thing that I thought I would point out here is that, we don't really have medical costs attributable for people in recovery. what we've got is we're kind of assuming that people in recovery and people who've never tried OUD, the medical costs and societal costs are the same. That's probably not quite true, so I'm kind of looking for a solution there, because I think that, someone who is like been in recovery for 1 year, they could have reoccurrence, and then, having, at worst case scenario, an overdose or something. Okay, and that certainly can happen. It's probably more likely to happen than if you've never had OUD. So that's something for a future direction. Okay, next slide. Yeah, so like I was saying, we want to look at the OUD medical and societal costs for people in recovery. We need to do a sensitivity analysis. This, as you've seen, there's a whole lot of parameters in here. And so a sensitivity analysis, you can kind of think of like redoing this analysis 1,000 times, having a distribution for the parameters, draw from them, rerun the model, collect all the data, and do this 1,000 times. And then you can get a probability of it being cost effective or not. And it's, you can do acceptability curves and things like that. We haven't done that yet. Where perhaps another thing we could do is add, in our not our current STT proposal, but our next one is going to have a residency calculator, so people like that are running these around the country could put in numbers, for their residents, and then pop out a result. That's kind of a long-term goal, and I'm working with Kim and Patrick, perhaps Sierra. I'm not sure. We're not sure. It depends on NIDA. And let's see. And I also want to thank Sierra Castello Martel and Marnie Moore for their help with the R24 grant, because we had a head start on this model for sure. Okay, with for Project Homes. Okay, and then next slide. And then these are the co-investigators, and this is the Project Homes team. Okay, next slide. So thank you. We can take questions now.
Thank you, Dr. Wilkerson and Dr. Brown. We will now answer some questions from our audience that have been submitted during the presentation. Just a reminder, please be sure to type your questions into the Q&A section. While we wait for questions to roll in, do you have anything else you'd like to touch on? Okay, we have one question in the Q&A. It says, I missed what Dr. Wilkerson said. Where is the new Project Homes house for women with children?
Yeah, great question. So we have 4 houses for women with children. We have 2 in Midland that take women with children up to age 18. We have 1 in San Angelo that takes women with children up to age 1. And we have our newest home in Houston that takes women with children up to age 18. And all 4, of course, also take pregnant women. And if you're interested in connecting someone with those services, again, you can reach out to our team. And our contact information is, there you go. Sean Wheeler is our project coordinator. You can call him directly on that phone number. And you can also fill out our form at go.uth.edu/homes. And a member of our team will be in contact with you to help get someone connected.
Very good. Do we have any other questions? Please post them on the Q&A section. Okay, it looks like we have a comment in the chat. Can you post a website here for the project, for the Homes project?
Is it on the first slide, maybe? I think it's on one of the first slides that Mike was. Yeah.
There we go. So Joanna, there is the post requested. And it looks like we have another question from Roy. Can we use the calculator with other factors? Is this published and available for review?
Well, we don't have the calculator for residency homes yet. I could let's see. Do I have the chat capability? If I can remember what the should have this. Let me put the calculator in, but let me be clear. It's not for project homes at this point. It's for if you want it. There's two that we've got. One, if you want to buy naloxone for your organization. And then the second one is long-term PRSS support after coming out of treatment. Okay, so it's not for residencies yet, but I can put it in the in the chat if that would be helpful.
Okay, let's look at another question we have. When you're starting a new project, what's the best way to make sure you collect the inputs for a cost effectiveness assessment at the outset?
That is a really good question, and it's very difficult because it's sort of a lot of times I know I've talked to Mike. I'll say like there's you know there's like sea legs that programs get over a few years. Like the first year you think we're going to do this every week, this whatever, maybe a family night. Okay, then nobody shows up, okay, or something like that. It doesn't work, and so you don't do it, and then you're collecting all this information. So basically the issue I think sometimes is you're not quite sure what you're going to be including, so you end up including a lot. But it's going to be a mix of things that you get from the program. In this case, we got from the program, the peer recovery coaches. I haven't added in the educational part, and we also got in the percentage of people that remain in recovery, after successful discharge. Okay, and but then a lot of the other information is from the literature. The mortality rates are from the literature. We don't know, we wouldn't know. We've made an artificial control. So the mortality rates that are OUD attributable or for just, non-OUD, we had to get that from the literature, right? Because we're saying, okay, if you're in recovery and you don't get this help, what is the extra benefit from having project homes? Okay, so it's a collection of data that is some of it's from literature and some of it is from the program per se. I don't know if that helps. I mean, we basically, when I teach the class, it's just sort of like setting out the project. That's a whole lecture, so I could probably aren't going to be able to completely give you a list right here, but hopefully that answered some of your question, or at least partially.
Okay, let's move on to another question we have. How exactly do project homes differ from sober living facilities? Is the cost effectiveness the same?
The project home is with sober living facilities. So when we think about sober living, and we think about, so there are both certified and non-certified homes. And in the state of nationally, when we think about certified homes, there's 4 different levels 4, 3, 2, and 1. And 4 being the most highly structured, 1 being the least. In Texas, the way that manifests, and more or less nationally too, but in Texas, the way that manifests is level 4. At this point in Texas, we tend to think of that as a treatment facility. So you have some sort of clinical staff. Now, that doesn't always have to be true. in other states, but in Texas, we don't really have a level 4 house that's not really like a treatment facility. So that's that. Level 3 houses are staffed, but they're not staffed with clinical folks. They are staffed with peers, people with lived experience in recovery, but paid staff in some way. Level 2, same thing, paid staff in some way. The main difference between a level 3 and a level 2 house tends to be the amount of structure with their policies, and also the addition of life skills in a level 3. So level 3 is more highly structured than a level 2 and has more life skills programming. A level 1 is not staffed. A level 1 is what we tend to call an Oxford house here in Texas and across the nation. An Oxford house is peer ran and self-governed, but there is an organizing body with those homes with which those homes are affiliated. So I hope that helps.
Okay, given these findings, are there any future directions you see for the future of recovery housing?
I think I'm excited, and Sheldon, please jump in, but I'm excited about Dr. Brown's analysis, right? I think there is a lot more analyses to do, but we began this project not knowing if this was cost effective or not, right? Is this a good investment for the state of Texas or not, right? Should we be funding this, right? If we can show, and this is my opinion, right, over time with this is a good start and we keep building on this, if we can show that this is a way to save money, then maybe down the road we can get recovery housing covered by insurance, right? Maybe we can get recovery housing covered by Medicaid. That would be huge, right? If we could get those things covered. There are some equity challenges right now in who can access this housing. Right now, you have to have, if not Project Homes. Project Homes, the state has taken that away. But at large, when we think about recovery housing, you have to have the resources to pay for this, right? To pay for this service. And oftentimes, when you have people entering recovery, most are unemployed. A lot are coming out of treatment or out of the criminal justice system. They're starting over, oftentimes, right? And so they don't have a lot of resources to pay that rent. And if they don't have family members or friends who are willing to help offset that cost, then this is not a viable option for a lot of people as part of the recovery journey. And that's kind of when I started this whole conversation. We're so blessed to have the funding from the state of Texas because they take care of that, right? The state of Texas right now is paying that rent, and that's tremendous. Like, I can't tell you how important that is. We have, and we've done like 90, nearly 100 interviews with residents, and every single one of them pretty much says, if it weren't for the fact that this rent is covered, I would not have the space to heal and work my recovery plan, right? And I think that Shelton's data is showing that the payoff is there, right? Like, these guys are more likely to maintain their recovery. They're less likely to return to use. And we're starting to get some numbers and data to support that. And when you start talking to policymakers, they want to hear dollars, right? The personal anecdotal stories that we're collecting are great. The quantitative behavioral psychosocial data we're collecting is great, but oftentimes a politician wants, in my opinion, they want to hear the bottom line. What's the dollars? And Dr. Brown is filling that piece. That's just my opinion. So I'm excited about what he's found and the potential for where this work can go. Dr. Brown, please jump in. I kind of took a little longer there than I should have.
Yeah, I would just say that like I mean, just sort of crudely, I mean, rent is way cheaper than jails or hospitals. I mean, the medical costs are so, almost $13,000, attributable to OUD in a given year. I mean, so if we're one of the issues I think with getting reimbursement is the the fact that like if you're Medicaid or private insurance, people don't change jobs and things, and so it's kind of hard to get. And even if you're in Medicaid, you get disenrolled. We kind of make it hard to get back in. Okay, and so a lot of times the insurers might think, well, if I pay for this, and then they switch firms, I'm saving money for somebody else down the road. And so they might not want to spend money in that way or invest in that way. But it's kind of like the medical and societal and medical cost for people with active OUD are so much higher that I think that in this case you can fund something like Project Homes, and it's cost saving. That's not really I think that I've talked about things that I can do in the model, but I think that as long as we're not including the time cost of the residents, it's going to be cost savings.
And just talking about other research, right? I mean, we can talk about that. We can think about the cost of overdose averted, perhaps down the road, right? If we look at, you asked about future research, right? You can have cost averted of overdose. You can think about co-occurring diagnoses. There's a lot of directions this could go, in my mind, at least. So I think it's a very exciting start to this work, and I love what Dr. Brown has brought to the table and to our team in that way. And I want to thank him publicly for this work, right? Because I think it's wonderful. So that's that.
Thanks for having me on the team. I'm hoping that with other grants, like what we could do is use the information from Project Homes to make a calculator. And then if, say, another state wants to do the same thing, they can plug numbers in and get the evidence to advocate for funding, whether it's through a private insurer or through the state. Because it's kind of hard to get economic evaluation. You got to find someone, you've got to get them on a team, and it's not, if you hire a consulting firm, it's expensive, so basically that's what we're part of what we're driving with this is to kind of spread it beyond Texas.
Very good. It looks like we've covered the questions that are in the Q&A, but we do want to give the opportunity, if anyone has any other question that we can answer for you, please post it in the Q&A section. All right. Looks like we've covered all the questions. So I want to thank everyone for attending today's webinar. The recording, the slides, and the resources mentioned will be posted on msdcenter.org. We ask that you please scan the QR codes on your screen to view more webinars and to register for our upcoming webinars later this month. A Food First Approach to Cardiometabolic Health webinar series sponsored by Avocados Love One Today, Part 3 on May the 6th, and Fostering Mental Well-Being, Strengthening Support Systems at Home, School, and Beyond on May the 20th. Thanks again for joining us today, and we will see you next time.